So just in the realm of busting myths in psychotherapy, you've said a trauma narrative isn't necessary. Exposure therapy isn't necessarily necessary. The body focus, the primary body focus is not necessarily necessary. How about the idea that is very prevalent in the field that the client needs to be somewhat stable to begin trauma therapy, that they can't be actively dissociating. They can't have, you've got to do all these other things like grounding for, several sessions, or teach them all these sort of techniques so that if they get too triggered, they have something that can pull them out, which is, something I was taught, that they have to have some basic grounding skills before you can even begin the treatment. This question is coming up in the chat, so curious about your response.
I was taught it too. I literally spent 25 minutes one day trying to find the perfect rock that had a groove that my patient could rub her thumb into to ground. I would come up with things like feel the chair, feel the earth under your feet. And what we know, all of that is passive grounding. So it's kind of like my physical therapist told me this week as he's jabbing needles in my back and he's forcing me to do horrible exercises. Yeah, Kate, you can get a massage, but that's passive recovery. And I was like, what an interesting way to think about it. He goes, now, if you went for a deep tissue massage, we might talk. Same thing. If you're doing all of these things, even Edna Foa has removed breathing retraining from prolonged exposure because none of these things quiet the amygdala in any significant way. They're very quiet, very passive interventions. If the goal is to make that amygdala stop hijacking, stop being overreactive, one of the best ways to do it is to be cognitive. And so, yes, I was taught that we had to get clients ready. We had to get them off their substances. They couldn't have suicidal thoughts. They couldn't be dissociating. We couldn't have been more wrong. All of those clients, we delayed therapy for sometimes 10 years before they were equipped and ready to go in. And the truth is, we do take dissociative patients. We do take suicidal patients as long as they don't have an imminent plan straight into CPT. And I'm very careful about saying this, but I want to praise my staff. I took over my program here in the VA 15 years ago and my program at UC at the university 5 years ago. I haven't had a single suicide in either program since I took over. That's unheard of. But the reason is because we're all evidence-based. We don't delay. We don't fragilize. If a patient is saying they would like to be looked at for PTSD care and they have PTSD, we start them at session 2 after their intake. Intake session 1, start them right away. And it really meets the patients where they are.